The HAL method is used to treat low to medium-grade hemorrhoids. The AMI HAL Doppler system allows the hemorrhoidal arteries to be located precisely in each individual patient. Special Doppler ultrasound equipment is used for this purpose. The handle is equipped with 3 high-performance LEDs, which ensure the light is sufficiently bright at all times to allow the surgeon the best possible vision. A probe containing an integrated ultrasound sensor is attached to the handle. This sensor can also receive the Doppler signal, as well as measure the depth of the arteries. An outer sleeve is placed over the probe. The procedure is very simple. The surgeon works in the area contained by the ligation window. After inserting the Doppler probe all the way into the rectum, the surgeon starts to look for arteries at a depth of 4 to 6 centimeters. Here, careful attention is required. The handle with the probe attached is turned slowly until the first artery is detected and then held in this position. The depth of the artery can now be seen on the display. The strength of the Doppler signal indicates the center of the artery. Ligation can be carried out safely up to a depth of 8 millimeters. A 5/8 needle from AMI is placed into the needle holder and then inserted into the probe. The surgeon then ligates the respective artery through the ligation window into which the mucosa is falling. Due to the rectal blood vessels frequently changing their course, it is vital that the ligature be placed as close as possible to the Doppler ultrasound. If this is not the case, there's a high risk that the artery will be missed. A second stitch usually follows the first. Subsequently, the needle is cut off from the suture, and the 2 suture ends are knotted together. The result is a figure of 8 knot. Now the handle is turned slowly until the next artery is detected and ligated as before. This continues until one complete rotation has been made and all arteries ligated. In most cases, 5 to 7 arteries will be found. However, this can vary considerably from patient to patient and may also depend on the severity of the hemorrhoids. Subsequently, it is advisable to pull the handle back 1 to 1.5 centimeters and to make a second round of ligations on this plane. The result of these ligations is a reduced blood supply to the hemorrhoidal cushions, and hence a far better balance between the inflow and outflow of blood. In time, the hemorrhoidal cushions shrink, and the success of the therapy is evident some 6 to 8 weeks after, when they are back to normal. Because the method is based on the principle of reducing the arterial blood supply, HAL is extremely effective in relieving the symptoms of hemorrhoidal disease caused by excessive pressure in the arteries. Bleeding, itching, and pain are treated with great success, regardless of what degree of hemorrhoids. The RAR method is used to treat higher grades of hemorrhoids involving a prolapse, which needs to be repositioned inside the anal canal. The term RAR stands for recto-anal repair, a combination of the HAL method as previously described, and 1 or more mucopexies of the prolapsing mucosa. Before executing the mucopexy, it is important to ensure that ligating of the arteries is carried out with similar care and diligence as for the HAL method alone. Only this way can we treat the symptoms of bleeding, itching, and pain successfully and achieve the same results as with HAL. Once all ligations are in place as for the HAL method, we can move on to the next step involving a running suture for each prolapse. Alternatively, the running suture can be placed immediately after the ligation using the same suture material. The mucopexy can also be performed with ease using the AMI HAL Doppler system. The AMI RAR flexi probes are made up of 2 components, an inner part that is connected firmly to the handle and an outer sleeve that can be rotated. The handle is moved to the starting position used for ligation. The ligation window and hence the handle point to the position requiring treatment. The RAR flexi probe must be inserted into the rectum in such a way that the prolapse can be lifted to maximum effect. As for HAL, AMI's 5/8 HAL needle is inserted into the initial stitch placed. If necessary, the mucosa can be pulled gently into the RAR probe after making the first stitch to allow more proximal placement of the second one. This results in a Z-shaped stitch. By successive turning of the handle, more and more mucosa becomes visible. Proceeding step by step is important to prevent all the mucosa falling into the probe's ligation window at once. Continuing in this fashion, the surgeon places a running suture which ends between 5 and 10 millimeters proximal of the dentate line, still in the pain-free area. The individual stitches of the running suture are placed some 7 to 10 millimeters apart, allowing room for 4 to 5 stitches in total. Once the last stitch has been placed above the dentate line, the needle is cut off and the upper end of the suture material by the initial stitch is then knotted to the distal end of the suture. This causes the prolapse to be pulled up in the direction of the initial stitch, where it is then secured in place with a sliding knot. The number of mucopexies differs from patient to patient, and the surgeon will decide how many are necessary as the operation proceeds. As a general rule, between 2 and 4 running sutures are required. However, it is certainly possible to perform more or even fewer.